Anthony, de bedoeling is ook dat dan eigenlijk... Hoor je mij, Anthony?
Anthony hoort u niet, maar...
Ah, die hoort mij niet. Oké.
Ah ja, ja, Anthony hoort u wel.
Anthony hoort mij. Oké. Anthony, dus tussen de verschillende sprekers in mag je eigenlijk altijd dan naar dit beeldje terugkomen waarop dat het programma staat als ik dan de volgende aankondig. Dank u wel.
Doet het werk? You're using the computer.
Nee. Ja, als we spreken.
Ja, maar als gereageerd.
Ah, ja.
We staan er niet met elkaar op.
Nu, als we spreken.
Ja, wacht.
Welcome to the lunch session of our webinar on the proceedings of interventional clinical trials in COVID-19. My name is Eva van Brakel. I'm a pulmonologist at Ghent University Hospital and your host for today. And we'll discuss both the antiviral and immunomodulatory approaches of COVID-19. Questions can be asked through the chat function in the YouTube channel and will be answered at the end of the webinar. So I'm proud to introduce Professor Bart Lambrecht, who is the director of the Center for Inflammation Research at the Flemish Institute for Biotechnology and Ghent University. Besides that, he's a certified pulmonologist and part of our staff at Ghent University Hospital. Bart will guide you through the pathogenesis of COVID-19 and identify potential druggable targets.
Okay, thank you very much, Eva. So I'll start sharing my screen if I can find it. Okay, so I'd like to take you through some basic pathophysiology of COVID-19. I think many of you are already fully aware of the clinical perspectives of this disorder, and we thought it might be very informative that we tell you a little bit more how this disease leads to such a severe lung injury and how this could lead to the identification of druggable pathways. So, first slide. So this is the enemy. This is a SARS coronavirus 2. We won't go into too much detail, but suffice it to say it is called the coronavirus because it has this crown-like structure with spike proteins. And these spike proteins are used by the virus to enter into cells. So it's very important to understand that there are various phases of this disorder. Initially, stage 1 of the disease is mainly characterized by a viral response phase where our innate immune system will try to fight the virus. This will lead to symptoms such as fever and maybe some malaise and myalgia. But this phase usually wanes in a couple of days. Then there's a second phase of the disease, which we call stage 2A and 2B of the disease, where progressively patients will get more respiratory symptoms. They will get more dyspnea, coughing, dry cough particularly. And this phase can also be accompanied by hypoxia, which is shortage of oxygen in the tissues. At this phase of the response, in phase 2B of the response, something very important is happening. There's an increase in the host inflammatory response. There's progressively more lung damage. And by all means, we need to try to get patients into this phase 2B and prevent them from progressing into this hyperinflammatory phase where the lung injury is so severe that we can have signs of ARDS, acute respiratory distress syndrome, and even systemic inflammatory response syndrome and shock and cardiac failure. And you will hear from the next speaker, from Stephen Collins, how we can actually zoom into the therapy of the viral response phase. And I will talk later into how we can zoom into this host inflammatory response phase to come up with new drugs. So, but suffice it to say that the big challenge in our healthcare system is on the first hand, elderly people who are dying of a viral response phase because they can't stand a fever, and then the second challenge is the ICU overload with people being ventilated for prolonged periods. So if we can reduce the viral response phase by giving antivirals, or we can prevent people from progressing from hypoxic lung disease into ARDS and ICU uptake, we can do something meaningful for this disorder. So this is actually showing you how an alveolus looks like in a steady state. The prime function of an alveolus is to do gas exchange. So gas exchange happens across a very, very thin barrier. This barrier is only 0.3 micrometers thick, and a lung is built to actually exchange gas in our body. So if you want to defend a lung and you want to prevent a pathogen from crossing this 3.3 micrometer barrier, you have to have a very, very active immune response, a very strong inflammatory response. But this inflammatory response needs to go away immediately, because if it's not going away immediately, you're going to compromise gas exchange, which is also happening across this 0.3 micrometer barrier. And there's a few things that do this. There's a very important cell type called the alveolar macrophage, which I like to compare to a vacuum cleaner of the lung. It takes away all the pathogens that are inhaled. It will phagocytose them, and at the same time prevent lung injury. It will just neutralize those pathogens without causing an inflammatory reaction. These same macrophages are also important for surfactant homeostasis. So surfactant is the detergent that keeps our alveoli open. And if you don't have alveolar macrophages, actually your alveoli will collapse, and this will severely compromise gas exchange. And the third thing that is very important in the lungs, that when there is T-cell influx in the lungs, which we see also massively with COVID-19, when there is T-cell influx, those alveolar macrophages will do everything they can to keep those T-cells in check and to keep them quiescent. And this is called energy of T-cells. So alveolar macrophages are anti-inflammatory cell types. So what happens in early COVID-19 infection? This virus has tropism. It likes to infect lung epithelial cells, both bronchial epithelial cells, but particularly alveolar epithelial cells get infected. Alveolar macrophages, this very important homeostatic cell type, is infected. And then very strikingly also endothelial cells, which are crucial, of course, for gas exchange, are infected. And Steven will talk to you about the various targets there, but suffice it to say that the virus comes in via the ACE2 receptor. It's using another protease called TMPRSS2, which helps in the unfolding of the virus. The virus enters, it's injecting its RNA into the cytoplasm. It's a single-stranded RNA virus. This leads to protein production, and then progressively you will have a replication of the virus, and in the process the cell gets killed when this replication happens. So how does our immune system respond to this? So initially the immune response is very good in this infection. So initially the immune system will do its job. The alveolar macrophage will ingest the virus. It will produce cytokines like TNF-alpha and IL-1 and IL-6. And the epithelial cells will produce type 1 interferon. And type 1 interferon is a so-called antiviral state. It will prevent the virus from spreading. Part of the reason why elderly people are so susceptible to the disease, we think, has to do with their slower and and less consistent production of type 1 interferon, so that they don't fight the virus very well. And this leads to higher viral loads and potentially also more viral spreading from an elderly patient. The cytokines and chemokines will recruit some neutrophils and other cells into the lung, but this is all very good. It's meant to kill the virus. But then something can go terribly wrong. This is a patient we saw last week, referred from another hospital. And this is an image here from, I'll come back to that patient in the second part also. This is a CT scan taken at the 5th of April. Well, you see there's mild ground glass opacities here in the lungs. And you really see that this is an inhaled pathogen. So it follows the bronchocentric distribution. But then all of a sudden, 5 days later, this patient is in deep trouble. There's widespread alveolar edema, there's crazy paving on the CT scan, and there is a very, very strong consolidation and alveolar filling across this CT scan. I only have one image here of this patient, but it's coming back later. So why does it go so wrong in some patients? So this brings me to this second phase of the disease, where the host inflammatory response is actually kicking in, and in some patients is doing much more harm than it is doing good. But by that time, most of the virus is already cleared from the body, yet it's like the immune system doesn't know the virus is gone, and keeps on firing off and keeps on inducing lung inflammation. This is really bad at this stage. So how does this look like? And this is now a typical thing that you see with acute lung injury, and this can happen, for example, with influenza as well. So the virus, remember I told you, it's infecting capillary cells, capillary endothelial cells. The virus will actually hit the capillaries. This will lead to microthrombi in the vessels. There's also loss of ACE2 function, the receptor that's used for internalization, that is then lost when it's internalized. This leads to an upregulation of bradykinin, and bradykinin is very well known to many physicians. It's a cause of cough. So chronic coughing is caused by bradykinin if you're on an ACE inhibitor. But bradykinin in this particular disease is pretty bad because it will cause the contraction of capillary endothelial cells, and this will lead to leakage of plasma and edema in the alveoli, leading to alveolar flooding. And this is how we see it on the CT scan. It's these extensive ground glass opacities that are happening. At the same time, the recruited neutrophils start going into overdrive. They produce ROS, and this will lead to further capillary leakage. That's why we have to be always careful giving too much oxygen, and this is very well known to the ICU doctors. Second thing that happens with acute lung injury is that the capillary problems start extending from the capillaries into the tissue. So there's a release of clotting factors. Tissue factor 7 goes into the extracellular space, activating thrombin, fibrin deposition, and you get formation of so-called hyaline membranes, very typical of diffuse alveolar damage and acute lung injury. And this is also the reason why we see in the bloodstream of those patients, we start seeing the accumulation of D-dimers. A lot of patients will get a D-dimer test in the beginning of their admission because of a differential diagnosis with lung emboli or pulmonary embolism. But we see that as the patient progresses during acute lung injury, the D-dimers start going up again. This is not because there's necessarily a pulmonary embolism. It's also inherent to the disease process. It's because of all this fibrin deposition into the alveoli. Next thing that happens is that CRP gets deposited into the lung. So CRP in this disease is much more than just a biomarker for inflammation. It's actively contributing to the disease. It has been shown very clearly in MERS and SARS-1. CRP has the potential to activate complement via complement C2, leading to C3 and C5 activation. And these are perfect chemotactic factors for the next step of the disease, which is massive accumulation of neutrophils and pro-inflammatory monocytes. And those cells will actually be the reason for the so-called cytokine storm. Those pro-inflammatory monocytes that come in, they actually produce IL-1 and IL-6 and chemokines. So the whole thing gets amplified much further. And this is how you end up with these widespread abnormalities in a couple of days. So what is next in this disease process? It's a little bit too early in Belgium to see this, but it's very likely that some of those patients will evolve into a more proliferative phase, a protracted course, and potentially evolve into lung fibrosis. This is typical of diffuse alveolar damage, and any ARDS, this can happen. So how is this initiated? When there is insufficient clearance of the hyaline membranes from your basement membrane, and the virus is gone, what will happen is that your type 2 pneumocytes, which have stem cell potential, they will start restoring the whole thing. They will start hyperplasing, so they will start growing. And if the basement membrane is not intact at that stage because it's covered with hyaline membranes or with fibrin, those cells don't know where to go. They start proliferating, but they have nowhere to go because the basement membrane is not empty. So they become frustrated. I always tell to students, they become frustrated. They start making TGF-beta, and this leads to fibroblast activation. And those fibroblasts initially will just be under the basement membrane. But if the basement membrane is damaged, like often the case in diffuse alveolar damage, the fibroblasts will also grow into the alveoli and into the terminal bronchioli, and this will cause so-called cryptogenic organizing pneumonia, or COP. Old name of this is BOOP, and this is really the protracted course of a diffuse alveolar damage. It can be steroid sensitive when you give it at the right timing, but it's too early to say whether this would be steroid sensitive. But we know this is a cocktail for later lung fibrosis and for later bronchiectasis in those patients. And we're carefully going to look at that, of course, in the future. What we are hoping for is complete repair of lung injury, and this can really happen. I'm not saying that every patient will evolve into lung fibrosis. There is still a possibility of complete restitution of disease, providing that the alveolar macrophages can come back, can do their job, and start cleaning up the dead cells and the debris. And a very important cytokine in that regard is GM-CSF. So GM-CSF is normally made by a healthy epithelium, and it causes the inflammatory monocytes to differentiate into alveolar macrophages so that they can do their vacuum cleaning function again. And the GM-CSF will also cause the alveolar epithelial cells to grow back and to repopulate the damaged basement membrane so that you can have a full reconstitution of the lung injury. Why are we hammering so much on GM-CSF? Because it's been shown that the SARS coronavirus can actively suppress the production of GM-CSF. And a group in Singapore has just sent us data yesterday showing that the GM-CSF levels in patients with COVID-19 are severely reduced, not only in the lungs, but also in the serum of those patients. So I'd like to hand over the word to Steven, who will talk more about the antiviral strategies.
Okay. Oh, you should stop sharing your. Yep.
So our next speaker, Professor Steven Collins, while he's installing his presentation, is the head of department of the General Internal Medicine and Infectious Diseases at Ghent University Hospital. And he will discuss the antiviral treatment options. It's all about the timing, isn't it, Steven?
It is about the timing, but yeah, I have a problem with the computer now. There's a security setting. I have to stop Zoom and re-lock.
Then maybe in the meantime, I'll answer a very short question whether there is still a BCG vaccination given in Belgium. No, this is not the case in our country. So remember, while the presentations are ongoing, you can always post your questions on the chat, which we will answer with our panel at the end of the webinar. Besides Professor Bart Lambrecht and Steven Collins, we also have Professor Erik Hoste on board, who is an ICU physician at our hospital and who can also tackle ICU-related questions. In the meantime, I think Steven has got his presentation ready. Go ahead.
Yes, I do apologize for the small delay, but my security settings were more severe than I thought, which is never a bad thing, obviously. But I suppose that what you heard from Bart is indeed that it's all about the timing, and especially in the antiviral strategies, which have a worldwide impact now in clinical trials, and we're doing wonderful things with that. But antiviral strategies should come at the beginning, as you have seen, as the pathogenesis of the disease is different from other viral diseases. So Bart already showed you this slide, and I'm going to talk about the possible antiviral treatments. And when I saw this publication, I was quite surprised that potential strategies, the antiviral strategies were stretched out into the host inflammatory response phase. Because you would suspect when the virus is absent or not proliferating anymore, that the effect of antivirals is not as important anymore, and is probably what we are seeing now in the clinical trials. There's different targets for the direct-acting antiviral drugs, and indeed, as Bart has shown out, we have a very nice target, TMPRSS2, which can be compared a little bit to the CCR5 inhibitors we have in HIV. Chloroquine and obviously hydroxychloroquine have been pushed very early in the phase. it inhibits viral entry and endocytosis. It increases the pH, etc. For the and the virus can more difficultly spread within the lungs. There's protease inhibitors, especially lopinavir, and there's some trials ongoing with darunavir that inhibit protease cleavage. And then the broadly acting antivirals on polymerase, such as ribavirin, remdesivir, and favipiravir, are obvious molecules that can be used to stop antiviral treatment. There has been a lot of drug repurposing. A lot of in vitro data has come out, and some of the older drugs that we know, which are widely available, such as ivermectin and itraconazole, also work in different ways and are being pushed within clinical trials now, even within in Belgium. However, when you look at the pathogenesis, when the patient does have exposure a couple of days ago, there's an incubation period of 5, 6 to maximum 14 days. And then when the symptoms develop, then obviously the virus is already replicating. But we don't see those patients coming within the hospital with those early symptoms. We do see patients coming later on when they deteriorate and when they present themselves to the emergency ward. And it's only a couple of days later that the patient is then admitted to the ICU. Now, we have an antiviral window of opportunity, which is actually from exposure until the deterioration, and then the viral load is going to go down, and then we come into this immune modulatory window in which Bart is obviously going to talk some more. Now, this is the window of opportunity that we are looking at now to treat those patients and to do the antiviral drug trials that are ongoing now. And that may be too late. We should look earlier. We should look at PrEP. We should look at PEP, so pre-exposure prophylaxis. We should look at post-exposure prophylaxis, and then start treatment earlier, as has been argued by Bart also. Now, what can we expect from the treatment when we give it? This is a nice modeling study, actually, that has been done. It hasn't been peer-reviewed, but what they did is look at the potency of chloroquine and remdesivir, and I'm only showing data on the chloroquine, and then what you might expect from this chloroquine and remdesivir treatment after days of first positive viral load. And as you can see, we expect actually patients to come into the hospital within the 5 or 10 days that the virus is already replicating. Now, when you start this treatment, then you're already in the downslope of the viral replication. And so depending on the potency, which is hypothetical at this point, but depending on the potency, you will see a reduction of the viral load. Now, the later you are, the more inflammatory response you're going to have already, obviously. If you start at 5 days, the effect is going to be much faster. If you start at the peak, so let's say in the ambulatory phase, when the patient still doesn't have too many symptoms, you will indeed have an effect. But if the potency is not good enough, you might have a prolonged viral replication. And if you start very early after exposure, with high potency, you will eliminate the virus. With low potency, you have also a possibility of a second peak or prolonged viral replication. In the case of C and D, you might also thwart your immune response, so the antibodies might go down, and this might indeed, again, lead to problems in the second phase of the disease. So the timing of antiviral treatment is extremely important. Now, yesterday I looked at Clinicaltrials.cov and WHO landscape of therapeutics, and I counted the amount of compounds that are under investigation, and I only found like 26 of the 133 compounds that I could identify and maybe promising that are antiviral. Most of the clinical trials that are ongoing are anti-inflammatory or immune modulatory trials. Now, there's one trial I didn't include, which was on natural honey and COVID. I don't know how it gets on Clinicaltrials.cov, but that is the one that I omitted. So I was biased a bit, I have to admit. So before I go to the next slide, which are the more promising drugs that has been widely studied? And obviously there's chloroquine, there's remdesivir, there's camostat, an entry inhibitor, ritonavir, lopinavir, azithromycin has been studied, but also ivermectin, itraconazole, and favipiravir. And I will focus on the ones on which we have some data. Now, I do invite you to look at the titles of the slide, because I'm going to show you the level of evidence from some trials to expert opinion. And the data is coming, but it's still not very firm of what we have. These are some of the early trials that were published, and the first much publicized trial was in France, obviously, in which a combination of chloroquine and azithromycin was given, but it got a lot of comments because of methodological problems. They did see a decrease in viral load in respiratory secretions after 5 days, but the science was shaky at best. There has been a study also which claims to have included more than 100 patients. It was a letter to the editor. The original data has not been published yet, or might have been published in another paper, but they also claim to inhibit the exacerbation of pneumonia, promoting a virus-negative conversion, and to shorten the disease course. There was another randomized trial recently published, still not peer-reviewed, of 62 patients, which showed that there was a time to recovery that was shortened and a more rapid improvement of pneumonia. And then another trial of 150 patients, which showed there was no increase in virus response, but it did accelerate the alleviation of symptoms, and there was a recovery of lymphopenia. So those were very promising results. These are promising results, but then 2 other trials were published in the course of the last 2 weeks, which was one, the Chlorovit study in Brazil, that looked indeed in higher dosing of chloroquine, but unfortunately had to stop inclusion and enrollment in the trial and the continuation of the trial, because there was a lot of side effects, more QT prolongation, and there was a trend towards higher lethality than in the lower dose. So the authors concluded that higher doses of chloroquine should not be recommended within the treatment of COVID-19, and they did not find any clear evidence of more rapid clearance of virus in the higher doses of chloroquine. There's a trial that was under review in the New England Journal of Medicine, in which 63 patients were included. And also in this trial, it was concluded that hydroxychloroquine was associated with a need for escalation of respiratory support. Laboratory parameters did not improve. There was a worsening neutrophil to lymphocyte ratio, and there was a high risk for intubation. This probably means that your timing of chloroquine is very much important and should be used in early phases. Lopinavir, ritonavir was also pushed very early on in the epidemic. Only one trial has been published so far. I can be very brief on it, in that in the patients that were included, there was no difference in time to clinical improvement. There was no reduction in mortality, and the percentage of detectable viral RNA at various time points were similar. Now, I do have to admit that this is a surrogate marker for me, as viral RNA is not proof of viable virus, obviously, and may take some time to clear from the body. But one trial that is not looking very promising. Last week also, the first publication with remdesivir appeared in the New England Journal of Medicine. This was an observational trial, which is obviously not very solid for evidence, but again, and was not randomized. There was no control group, even no historical control groups, which were mentioned in the studies. And this graph shows, or this table shows, that if you give the treatment to patients that come in relatively good clinical conditions, you will have a good outcome, but then you might wonder if the antiviral drug did anything. And if you give it too late in the disease, and the gray parts are patients that deteriorated, then probably your effect of the antiviral is not as big. And then lastly, what's the evidence on azithromycin? Well, there I put the level on expert opinion. You had the trial of the south of France that was published, but very shaky design and very shaky data presentation, to say the least. There was a 80 patients follow-up trial from the same group of Raoult. But again, there were some problems with the data. And then Molina in Paris, he published a small case series in which actually there was no add-on effect of azithromycin in the chloroquine group. There's other things to consider in these antivirals, and it's a very busy slide, but and I won't go into detail, but I would like to say that many of these drugs do have contraindications, which in the case of hydrochloroquine is more in the long-term treatment that we might see a problem, but especially the QT prolongation is a problem with this drug in ICU patients. And then there's important interactions that might occur, and the experience in our center from the intensive care unit physicians is indeed that you need higher doses of other drugs to be able to ventilate your intubated patients because of these possible drug-drug interactions. Also, the other drugs, they have important side effects for lopinavir and ritonavir. We know there might be serious gastrointestinal intolerance with important diarrhea. And as you know, that the virus might also be shedding in feces. There might be cardiac conduction abnormalities. And this is an important inhibitor of the CYP3A3 and other CYP cytochromes. So again, important interactions in your severely ill patients. Remdesivir is reasonably well tolerated as far as we know, but there's little evidence there's little experience with that. And then with the azithromycin also, you get this QT prolongation and less interactions that are possible. Now, there's different trials ongoing in Belgian center, and then it's Frank Hostad that sent these slides, for which I'm very grateful. So there's a trial ongoing with itraconazole in Leuven, in the Dawn trial. I understood there was an arm that was added for azithromycin. In Brussels, there's a ivermectin trial, and then Gilead Sciences has made remdesivir available for some centers to treat the patients. What we have seen in this pandemic, and this is a wonderful development, so we learned a lot of doing clinical trials in epidemic settings during the Ebola crisis, and WHO is now really showing leadership in this to start the Solidarity trial, a 5-arm trial that will compare standard of care with remdesivir, lopinavir, ritonavir with interferon, and chloroquine or hydroxychloroquine. It's a very simple trial that will look at all-cause mortality and a secondary outcome, duration of hospital stay, and time to first receiving ventilation. There's not a lot of data that needs to be collected, and also the randomization process is and inclusion process is quite simple. It's a worldwide trial. So a lot will be learned from conducting this trial, and it's an adaptive trial. So if new data emerges and new drug drugs emerge, they might add on some arms within this trial. And I know that some, if not a lot of centers are collaborating in this trial, not Ghent for reasons that Bart will explain and which I have explained now because I do believe in the timing of the antiviral treatment. So I would like to conclude that the evidence that we have now is not very firm, but the absence of evidence is not the evidence of absence. So these drugs might still be useful. And I would still say to everybody that our first principle should to do no harm. And so look at those interactions and look at those very specific side effects that you might have, especially the cardiac ones. Treat according to guiding principles, and Cienzano has very nice interim guidelines which are updated regularly with new data. Do it preferably in a trial setting if you do give any treatment. My personal thoughts is that we should avoid the Tamiflu conundrum, which is also sometimes put very late in the treatment of influenza, and which would probably benefit patients much earlier in the time of the disease. And so I am convinced that we should look for ambulatory trials, and I understand that Leuven is designing a trial for in the first line and in nursing homes. I think we need to look at biomarkers as guiding criteria to see in which stage that the patient is in. I also believe that solidarity trial is a very good first step, but we should probably think of doing multi-arm, multi-stage trials, maybe even on the Belgian level, because doing an international study has proven to be quite difficult, as Herman Hossens will attest to that. But I also see major issues with the antiviral treatments, the availability of drugs. If you don't have access to the drug, then what is the use of doing the trial? We do have some shortage of funds. If you do want to do such a MOMS trials, it costs money. If you want to include enough patients, so power should never be compromised. And then there's a lot of discovery ongoing for many old drugs and repurposed drugs, but I do stress that safety should not be compromised. And with that, I would like to hand back the word to Bart.
Thank you for this excellent overview, Steven. We'll switch back to Bart, who will zoom in on the immunomodulatory approaches to tackle COVID-19.
All right, so I'm going to give an overview of the immunomodulatory strategies that are ongoing here at Ghent University, but also at a number of other centers in Belgium. And it's certainly something that we're seeing now worldwide, as Steven was saying. I would say the majority of clinical intervention studies is around immunomodulation and trying to prevent this hyperinflammatory response. One caveat I would like to make already immediately is there's been some people who have been given these drugs on compassionate use base. I think that's also an advice from WHO and from the American Society for Infectious Diseases that all these things should always be given in clinical trials. These are quite dangerous drugs. If you give them in the wrong phase of the disease, you actually might cause more harm than good. So that's the caveat I want to give before starting. So we've just heard from Steven that targeting viral entry and replication is an early strategy, but what about later strategies? We've heard a lot about convalescent plasma. I think the jury is not out there. Certainly it's starting up. I mean, we have seen the calls for donors. Personally, we think here that it's very important before you do such a strategy that you have a good idea about the neutralizing titers in your donor plasma before you start doing it, because there's always the risk that if you have a low neutralizing titer in your donor plasma, you might actually be enhancing the disease, particularly when you give it too late in the disease when there is already diffuse alveolar damage. Remember, I was saying that there's a lot of plasma leakage. So if you have immune complexes coming in via that plasma leakage, and they don't neutralize the virus, but they just bind to it, this could actually lead to more complement activation and to more lung damage. So I think before we do this, we really need to know what the neutralizing titers are in those donors. Antagonize cytokines is one target. Antagonize complement. Always provide good anticoagulation and prevention of pulmonary embolism. The bradykinin pathway has been proposed as being used now in Nijmegen in a study. Promote repair and homeostasis is also a strategy with immunomodulators. And then eventually you want to try to prevent fibrosis. So the first strategy I would like to discuss with you, it's something that we have a clinical trial set up for in Belgium. It's running currently in UZ Gent and in Bruges, but there's 3 more centers joining at the end of this week. It's this idea that the recruited monocytes that come into the lungs are pro-inflammatory, and they should be turned into alveolar macrophages. So monocytes are the progenitors for alveolar macrophages, but in this COVID-19 damaged lung, there's a deficiency of GM-CSF because the virus subverts it and because epithelial cells are dying. So why do we think this is going to work? This is a study from China. It's a bit of a complicated slide, but suffice today in the lab now, nowadays we can do single cell RNA full genome sequencing, which means that it's almost like the Human Genome Project, but then on single cells, and then you do 15,000 cells, and you can do this in a couple of days. So this is pretty amazing. But this is not science fiction, it's reality. Also, our labs are doing that all the time. So what you see here, if you group the cells according to clustering algorithms, you see in healthy controls here, there's a population of cells called group 4 cells, which are completely lacking in severe COVID-19. And if you look at the gene expression of those cells, and this is depicted here, those cells express fatty acid binding protein 4, and this is actually the gene that is characteristic of alveolar macrophages. So in other words, in patients with severe COVID-19, there is a complete absence of alveolar macrophages, the vacuum cleaners that need to clean up the debris in our lungs after diffuse alveolar damage. So the rationale for the trial that we are doing, it's the so-called SARPAC trial for sagramestim in patients with acute coronavirus infection. It's to actually give excess GM-CSF via inhalation. We know GM-CSF is the signal that's driving monocyte to alveolar macrophage differentiation. We've done that research ourselves. We know that patients who have no functional GM-CSF because they have antibodies or autoantibodies to GM-CSF develop severe interstitial lung disease. So based on that rationale, we decided to move forward with a study giving inhaled GM-CSF to patients with COVID-19. And we gave it initially, well, particularly in this phase of hypoxic respiratory failure, but before people are actually ready for the ICU. So what you're trying to do is preventing the step up, into this hyperinflammation phase and this severe lung damage that keeps on maintaining itself by restoring homeostasis, by bringing those alveolar macrophages back from the tons of monocytes that have just been recruited into that lung. So this is the buildup of the trial. So it's a randomized open label trial, trial in 80 patients where people are randomized to receive either inhaled GM-CSF or standard of care. We didn't do a placebo-controlled trial because we thought it was unethical to unnecessarily give a saline aerosol in a group, with this disease. Because with these aerosol procedures, don't forget, you're generating an aerosol. So this could lead to a spread of the infection. So this is also where we are very, very careful. We here do it in negative pressure setting, but I know some centers do it on the regular COVID ward, but always use FP2 masks and do this procedure, at least 1 hour after the aerosol procedure nobody should enter that room. That's the advice we're giving. So people are randomized, and then they're either receiving 5 days of inhaled twice daily sargramostim or GM-CSF, and then group B gets standard of care for 5 days. And then our primary endpoint is actually at day 6, looking at oxygenation. However, if there would be progression of the patients in group A, the intensive care doctors, if the patient has moved to intensive care by then, if there would be progression, intensive care doctors have the potential to give IV GM-CSF both in the active group as well as in the control group, because our primary endpoint is over by then, and we want to give patients the benefit, you know, if they're enrolled in the control group, that they would still get some benefit from this study. So where does the idea come from? It comes from this paper that was published in the New England Journal of Medicine last year. It's where they've given inhaled GM-CSF in a very safe manner for 12 weeks in a row, daily inhalations of GM-CSF in patients with pulmonary alveolar proteinosis. So we knew it was possible to aerosolize GM-CSF, and we knew from our mouse work and from mouse work of others that if you have mice with severe influenza-induced ARDS, for example, and you give them inhaled GM-CSF, you can prevent them from dying. So this is the rationale why we did it. I must say all of this was done within 6 days. So we really want to congratulate also the ethics committee, you know, and particularly also the Federal Agency for Drugs, the FAG, for being on board with this study, you know, and they saw the urgency of this problem, and they really proceeded with a lot of sense of urgency. So how does it look like? We're using handheld mesh inhalers, who are very gentle inhalers. I run a video here. So this is a test person. It's actually a volunteer who's breathing the aerosol. So you do get some aerosol generation, but this is by no means the kind of aerosol spread you get with a jet nebulizer like most centers would be using. So it's a mesh nebulizer that doesn't destroy your protein. So the current status of enrollment is that we started on March 26. We now have 35 patients in the trial, and there's 3 more centers joining the study. We have several patients who are already are through their first endpoint measurement. One of the major things we wanted to know whether this is safe. It's a bit counterintuitive, you know. You're in a cytokine storm and you're going to give a cytokine, but we do not pick up any signs of toxicity for the moment. Just some mild coughing, which can be treated with a beta-2 agonist, and some taste disorders, which is also very typical of this disorder. Do we have target engagement? We really think so. So here the blue line is the people receiving, this is now 10 active, 10 controls. The people receiving the inhaled leukine, you get a nice increase in the eosinophils, which are often reduced in these patients, whereas in the control group, this increase is much efficient. I can say already, but it's too early to say it's an interim analysis, is we also pick up quite some nice effects on the improvement of the AA gradient, so the ventilation mismatching of the patients, and on the diffusion of oxygen in those patients. But there's more to follow on this probably next week, where we will do a formal press release on the results. Okay, so the second strategy that we're going for is this cytokine storm. So remember these monocytes that are recruited, the epithelial cells that are infected or have been infected, particularly the monocytes that are fluxing in during this diffuse alveolar damage response, they will start producing these very nasty cytokines that are initially good for your immune system, but if they go into overdrive, can also go terribly wrong. So these are the cytokines, IL-1, IL-6, TNF-alpha, that also play a major role in rheumatoid arthritis. So we decided, you know, we should look at the rheumatoid arthritis literature, you know, see which drugs are available, and then of course they're all available. You know, we have anakinra to block IL-1, we have tocilizumab and siltuximab and sarilumab to block IL-6 or its receptor, and we have Enbrel to block TNF-alpha. We decided upfront not to use TNF-alpha blockade because TNF-alpha is not just a pro-inflammatory cytokine, it's also very crucial for a CD8 cytotoxic T cell to kill a virus-infected cell. So we thought that was too dangerous to try out. And I think there's only one trial ongoing for the moment in the US where they're considering using Enbrel for treating the cytokine storm. I also mentioned to you that complement activation is happening. We're now at the stage that we're going to launch 2 clinical trials, also looking at complement inhibition. One will target C2 in collaboration with a biotech company, and then the other one will target C5. Okay, so how does the trial look like? This is the COVADE trial for coronavirus anti-interleukin drugs. It's an open label randomized trial in 342 patients. Currently with 10 centers are in the study, but we're looking into expanding this in the coming weeks with more centers if that would be feasible. And the epidemic is actually as it is now. The first randomization is between either receiving interleukin-1 blockade or not. So this is a 2-to-1 randomization. So most of the people are actually not on IL-1 blockade. And then within these 2 groups, we do a further randomization to receive an additional interleukin-6 blockade. So this group has usual care, and it's 2 out of 9 patients will have usual care, which is important to tell when you are asking for informed consent. So one group will only receive anakinra, and then one group will receive siltuximab, anti-IL-6, or Sylvant is the trade name only. A group will receive a combination of anti-IL-6 with anti-IL-1. A group will receive anti-IL-6 receptor, tocilizumab or Ruactamra, and then a group will have a combination of Ruactamra and anakinra. So this trial design is a so-called block design, so that you can compare on the one hand the IL-6 effect with the IL-1 effect, and only have to use one group of usual care patients. So this is ethically more justifiable, we think, and this design was actually done by the Federal Agency for Drug Use, KCE, Frank Hulstart, who's probably also online. So I can show you some patients. Of course, it's very early to say, but I must say we are seeing some spectacular results already in some of the patients who are on either IL-1 blockade or IL-6 blockade, or even the combination of the 2. So this is again the same patient I was showing you in the previous talk. So on the 5th of April, you have these mild changes in the lungs. By the 10th, it goes terribly wrong for this patient. And you see how the biochemistry is evolving. So this is a patient that was referred to us from another hospital. So you see here the 5th, everything looks okay. CRP 14. Ferritin is already a little bit on the high side. LDH is a little bit increasing. The D-dimers are normal. Lymphocytes are dropping. It should be 1500 per microliter. Eosinophils are already extremely low. 10 per microliter is very low for an eosinophil count. Most people will have an eosinophil count around 100 to 150. This almost looks like a person who's on benralizumab or mepolizumab. And there's no signs of bacterial infection. Procalcitonin is normal, and the PCR for COVID is positive. 3 days later, you see CRP is going up, ferritin is going up, LDH is going up. The D-dimers haven't been checked at this stage. Lymphocytes are dropping, and eosinophils are 0. This is already a very ominous sign. There's been a study in China that eosinopenia, or absence of eosinophils, is a very bad prognostic sign. 2 days further down the line, CRP is 201, ferritin is 3,800, LDH keeps on going up. The D-dimers now are positive. They're strongly, well, they're increased. The lymphocytes are still down, EOs are gone, and there's signs of intravascular coagulation. So fibrinogen is up. So I'll just run the CT on the 5th of April. You see here, everything looks okay. And then within 5 days, this is massive ground glass opacities. The patient had a score of 21 out of 25 on the severity CT score. So this is basically means that only 15% of lung volume is unaffected by the disease. So the patient was referred to us on the ER. Siddiq Bostils, who's one of the study doctors, got informed consent from the patient to get into the COVID trial on April the 10th. Patient was immediately randomized within an hour or so, and luckily got an active group, tocilizumab, anti-IL-6 receptor, single shot administration. And this is the biology over the course of 5 days. So it starts at the 10th of April at admission. This is yesterday, the 15th. Sorry, I didn't put it in here. But you see immediately you inject the anti-IL-6 receptor, the ferritin drops, the CRP drops from 202 to 2 milligrams per liter. The LDH drops, the eosinophils start returning, the lymphocytes start returning, the monocytes start returning, and there's no signs of bacterial infection. If anything, procalcitonin is going down. So in the trial, for safety reasons, because the CRP is so dependent on anti-IL-6, we, as a precaution, we ask every enrolled patient to have a daily procalcitonin measurement. And this is also part of the budget of the trial, because it's not yet reimbursed this drug. So the patient was, of course, this is a case, you know, we cannot make any conclusions whether every patient would react like this. But the patient was intubated, and already 3 days later was extubated again. He's doing completely fine. I saw him yesterday. He was having his evening dinner. This is how the CT looks like this morning. So you see that this heavy 21 out of 25 score has already gone down very massively. So you see there's still lesions, which is probably the COP phase, you know, this reorganization that's happening, but the extent of damage is severely reduced. So just out of curiosity, we calculated the AA gradient, which is you know, the difference between the pressure of oxygen in the alveoli compared with the pressure of oxygen in the arteries. Which you might remember from your ICU days. You know, it's a very important measurement of VQ mismatch and diffusion capacity. So when the person first arrived in the referring hospital, everything was fine. You know, AA gradient of 30, the age-adjusted AA gradient should be 18.5. So the patient is a little bit over, but all the biochemistry looked okay. So when the patient was referred to us, you know, 5 days later, the AA gradient was 245 millimeters mercury, which is dramatically bad. Even if you do an age-adjusted AA gradient, taking into account the 5 liters of supplemental oxygen via a mask, should be 33. So the patient is like 740% higher in AA gradient. Was extubated, and now his AA gradient is again to where he was, you know, at the beginning of his disease, 33 millimeters mercury with an almost normalized ratio of gas exchange parameters, diffusion capacity, and ventilation perfusion matching. So the final slide I have is, you know, how do we separate those patients apart when you would refer them or when you would be running those trials? So we always go for patients who have signs of hypoxia. So you shouldn't do this in a mild patient. There has to be hypoxia defined as a PF ratio below 350. And roughly speaking, this is a patient who has, you know, a saturation below 93% on 2 liters nasal cannula oxygen. There's a few exclusion criteria for the COVID trial. You can't have a history of myeloid malignancy because it's a growth factor for myeloid cells. And then in the SARPAC trial, we avoid patients with a cytokine storm. So the ferritin should be below 2000. And when they have signs of a cytokine storm and they have this same hypoxia when they are in hospital and they have signs of extensive disease on radiology and CT scan, and they are in the right phase of the disease, not too early, so between day 6 and 16, with signs of a cytokine storm like rising ferritin, A single high ferritin, if you can't wait, we have to ventilate immediately, a single high ferritin, or a progressive lymphopenia with a number of other criteria, we will actually enroll them into the COVADE trial, which is looking at these anti-cytokine drugs. The next study that is coming, I was saying it already, is going to be complement inhibition, because in that same phase of the disease, if you can block complement, we think you can also block the escalation of the diffuse alveolar damage. So that's going to start probably in a couple of days or maybe less than 2 weeks. Okay, and these are the centers where it's currently running. So we looked for geographic spread. So we have centers in Ghent, Brussels, Antwerp. We have in Hasselt and Genk, because there was a big epidemic there. We have West Flanders covered here, and we have currently 19 patients enrolled in the trial, which started not this Saturday, last Saturday. The study was starting. So here in Ghent, we have 10 patients in the trial now, and we're getting some very, very good results, I would say. But of course, very early to say, because that's why we're doing the trial. The main purpose of the trial is we'll be finally able to compare in a good setting whether these drugs do anything also in ARDS, because ARDS is normally a mixed bag of diagnosis. But if we do it early here, early in the same disease process, we'll probably be able to get some definitive answers whether IL-1, IL-6, or IL-6 receptor has synergy and has something fundamental to do in this disease process. But from the first results, it's certainly looking quite promising. And the same data are emerging in Yale, in Harvard, in China, in Italy. Although I must say that those trials mainly use later patients. So out of pragmatic reasons, we had to use the 2B stage patients because there was just not enough study medication. Everything went to compassionate use, was reserved for people who are being treated for rheumatoid disease. So this is why we go a little bit earlier, but in hindsight, that's probably very good, because if you're already 5 days into an ARDS, it's very hard to break that negative spiral. It's better to be safe than sorry, I would say, in this disorder. And this is the fantastic team of people who started working on this immediately, I would say. So we have 5 doctors here. You normally work at, they're all medics from trained in either internal medicine or ENT diseases. They are currently working at the VIB to do a PhD. They dropped everything and moved from VIB to the UZ Gent to do these trials. You see them here, Josephine de Klerk, Cedric Bosteels, Bastiaan Maas, and Elisabeth de Leeuw is not on the picture, nor is Karel van Damme. And then these are the study coordinators at the pulmonary department who had to do all of this in a very, very short time frame. And then the HIRUS, which is the Clinical Trials Center led by Katrien van der Straten, was really instrumental in getting all of this through the ethics committee with Charlotte Klauwaert and Joke Tommelijn. And then the study is heavily supported, COVADE study by KCE, the federal agency. The basic science is funded by VIB, and basically all of us are paid by University Hospital. So thanks for this.
So thank you, Bart, for this very inspirational talk and for sharing some preliminary results of these currently ongoing trials at our center, but also at many other centers. So it's 1 p.m., but I think we'll take some time for those who can stay online to answer some questions. And we'll maybe start with a more clinically oriented one from Lars Verreke, who asks, what is the advice for people under immunosuppressive therapy who undergo a SARS coronavirus infection? I think until now we've been judging this case by case. So in some transplant patients, for example, there is an opportunity to lower the dose of the immunosuppression. Of course, this is not feasible for every indication. So this really needs to be judged on a case-by-case base. I think we'll switch to Bart to go into detail, for example, on the anti-TNF. And so the other question was on the current experience with immunosuppressed patients at our hospital. I think it's too early to draw some firm conclusions, but we already know from literature that immunosuppressed patients are not the classical risk group in COVID-19. And what we tend to see is that indeed we have quite some immunosuppressed patients on the COVID wards. For example, kidney transplant patients, but we have the impression that only a minority of them indeed progresses to the more severe stage and would need mechanical ventilation. So, but that's something we will need to monitor more closely in the coming weeks. So maybe then we'll jump to this question also to Bart to comment on the on particular immunosuppressive drugs, and maybe also you can combine this with the question on the question of Philip Gevaert on mepolizumab, praslizumab, and other anti-eosinophil treatments, which is also then, I think, a very good question.
Right. Okay, so I think those questions are indeed very good questions. So we're certainly seeing that patients who are, for example, on CellCept, on transplant patients, we have the impression, I mean, we didn't do the formal calculations, but there's certainly an overrepresentation of those patients. Of course, we are an academic center with a big transplant program, so it's normal that we see a lot of those patients coming here. Nevertheless, you know, for those immunomodulatory strategies, you know, I would never give anti-IL-6 or anti-IL-1 to a patient who's on an immunosuppressant. That's also why we're excluding high previous doses of systemic steroids. You know, that's not a good idea because you're going to subvert the immune system too much. It's this delicate balance, you know, between being able to respond to a virus and not going into overdrive. I think if you're on an immunosuppressant drug, that would be the ideal candidate for an antiviral strategy. We have patients here who have agammaglobulinemia. We see, for example, that one patient is actually not clearing the virus because he can't make antibodies, despite the fact he's on IVIG. You know, there's no repertoire in there. So you really need a functional immune system for clearing that virus. The second question from Philippe Gevaert is a very good one. So there's emerging data from Denver and from UCSF showing that the ACE2 receptor is actually under control of type 2 immunity. So ACE2 is expressed as part of a mucus production program that we typically see in asthma patients. And we have the impression that we have an underrepresentation of asthma patients in the COVID epidemic. There's some data from John Fahey and UCSF showing even that people are on inhaled steroids, that the ACE2 receptor is downregulated. This is prior to the COVID-19 epidemic. So the question whether mepolizumab is good or bad, we're actually doing that question, Philippe. So we're treating as of today, actually in mice, we're treating mice with a mouse variant of mepolizumab. Because we do see that those patients have low eosinophils. It's a bad prognostic sign, but probably it's more a sign of the hemophagocytic syndrome than actually the lack of eosinophils, but we have to test it.
Okay, thank you, Bart. Then some other more immunologically oriented questions. Leander Meuris asks, you spoke of bradykinin signaling due to ACE2 suppression. Is this the main culprit in kicking off the massive lung damage, or is there also a role for angiotensin II and other ACE2 substrates?
Again, that's an excellent question. So, I mean, we have to go back then to how ACE1 and ACE2 are working. So, when you're on an ACE inhibitor, you're going to block ACE1, and then as a compensatory mechanism, ACE2 is going up. It's known that people on ACE inhibitors have an increase in bradykinin. You know, it's a very common side effect of those drugs is coughing. What we don't typically see is that those people develop alveolar edema or something. So you certainly need a second hit. But bradykinin is one of the most well-known mediators of the so-called plasma extravasation reaction. So I'm pretty sure it's contributing to the disease process, but just, you know, if you would just infuse bradykinin in a dog or something, and those experiments have been done in the 60s, this will not lead to alveolar damage. You clearly need more than that, but this is always the case with these immune-mediated diseases. It's always a cascade with one pathway feeding into another. But nevertheless, there is a trial that has been launched by Nijmegen University to block bradykinin.
Okay, thank you. Then another question from Ingel de Metz, who asks, is there an immunologic explanation why we see rather few of our COPD patients with COVID-19, which is indeed also the case in our hospital?
Exactly. So I think, I mean, we have to look at the reality. And in Belgium, a lot of people with COPD are on inhaled steroids. So it could very well be that the inhaled steroids that they are taking is actually causing the ACE2 receptor to be downregulated, and this might actually be the reason why we see very few of them. I know there's several groups in the US following that pathway for the moment.
Okay, then some practical questions considering first the SARPAC trial. So the MDI, is it always given in a negative room pressure? I think we can answer that simply. Yeah, it's been done like that in our center.
In our hospital, it's been on negative pressure. I mean, which does not mean it has to be like a formal isolation unit. What we did is we reversed actually the whole air conditioning system, which is probably possible in a lot of hospitals. But we did that already basically day one of the epidemic. So for us, it's easy. But I know in other centers, it's just used in the COVID isolation ward. What is a bad idea is if you would not have FP2 masks for your staff, you know, and then go in with a non-FP2 mask when a patient is using this mesh nebulizer. No, we don't do that. So what we do is we only explain it once to the patient with a study person, a trial doctor explaining it. And then it's so easy, this procedure. You just open the mesh nebulizer, they get a pre-filled syringe to empty into the nebulizer, and then they just do it on their own, and we leave them alone for an hour. So this is how it's going.
Okay, thank you. Then there's a question from Alexander. How do you exclude active fungal infection in the COVID trial? Well, I think this is not different from in other settings where this is a combination of clinical, microbiological, and radiological criteria. So, of course, patients, certainly on the ICU, they have their we have a system in place of surveillance cultures. Maybe Erik can comment on that. So we would catch an Aspergillus quite quickly. And of course, if there would be any suspicion, we would perform radiology and bronchoscopy if necessary to exclude that. But maybe Erik
Yes, I can confirm this. Twice a week we do surveillance culture. So I guess we pick it up quite early. And we proceed with CT scan or bronchoscopy if necessary.
So I think we have to distinguish very carefully. This is not a patient on chronic anti-IL-6 or chronic anti-IL-1. So in the rheumatology field, you will give this for years to a patient, and then you will have this gradual subversion of the immune system. And even so, in those patients, if you look at the data, there's only an increased risk of tuberculosis. We don't really see fungal infection being increased in people on chronic anti-IL-6. So what you also have to imagine, you give this to a patient with a cytokine storm. So you're cutting down the cytokine storm, you're cutting down the lung damage. So most of your antibody, which normally works for 1 month, if you give it in a rheumatoid disease IV, it's a 1 monthly administration. Most of that antibody will actually be consumed in the first days of your disease process because you have a lot of ligand. And once the ligand binds to the antibody, the antibody will be destroyed with the ligand. So it's not like your typical chronic immune suppression you would get with chronic anti-IL-1, IL-6 administration.
Okay, thank you. We have another question in the same line as Ingel's question. Have you observed any cases of people with CF or bronchiectasis infected with COVID-19? If yes, what is their prognosis? Well, actually, the CF community is monitoring this very closely. Until now, we don't have any large numbers of CF patients infected with COVID-19, nor in Belgium, nor worldwide. This has been reported. So until now, it's been monitored very closely, but there is no actual concern. We have had some people with bronchiectasis in our hospital who had quite a good disease course. But also this is something which will need to be monitored. Then we have two interesting questions for Bart from Leander Muris again. Do you have any idea on the availability of the biologicals for use in COVID patients in the case that the trials would show their benefits? Can production be upscaled easily?
So that's a tricky question. It's a very tricky one, and I think it's something that we have never witnessed in Belgium. We are used to, that everything is available for everybody. I can tell you it was a nightmare to get the study medication for 342 patients. We actually had to pay all that medication upfront without having a named patient. So it's like 900,000 euros in trial medication, which luckily was paid first by UZ Ghent and now will be taken over by KCE. But it's exactly the problem, Leander. So I know all the companies are massively looking into upscaling. All the RUAG Temra, the Sylvant, the Sarilumab, they will all massively try to upscale, but the production just is not there. But with FWO, we're actually looking into, maybe getting some projects funded, to see with the next pandemic, because those things will come back in the future, to have some, biotechnology preparedness. That there's so much expertise in biotechnology in Flanders and in Belgium. We have a lot of facilities that can produce proteins, recombinant proteins, even recombinant antibodies. But of course, they're not GMP certified, and that's the bottleneck. But I think in times of crisis like this, where you can save lives, I think we should look carefully in what GMP is meant for. GMP is meant for saving lives, to have safe drugs. But once a drug is working, if you can manufacture a drug according to good clinical practice and good laboratory practice, it should be possible. And I know the federal agency is also looking into this for preparedness in the future. For this epidemic, it's going to be too late.
Yeah, that's food for thought, Bart. I have one final question for you, and then two small questions for Steven left, and I think we will conclude afterwards. So, Bart, what are your thoughts on the use of mavrilimumab? It's the anti-GM-CSF-R alpha. I know you have some thoughts on that, which is currently going to be employed in a phase 2 trial in Virginia Commonwealth University early on in COVID-19.
I personally think that's scary because it's known that anti-GM-CSF has been in phase 2 trials for rheumatoid arthritis. It's been in phase 2 for asthma as well. So people didn't pick up any toxicity signals in the lungs. So the big scare was if you would give anti-GM-CSF, you would be inducing alveolar proteinosis, because that's what patients with alveolar proteinosis have. They have autoantibodies to GM-CSF. They never picked up this signal in the rheumatoid arthritis trials. But now we have something totally different. We have a leaky lung where there's a lot of plasma extravasation. Now your antibody is actually going to get to the compartment where the only cell in our body lives that's GM-CSF dependent. And the only cell in our body that's GM-CSF dependent is the alveolar macrophage. So if you're going to take away its growth signal, by giving a blocking antibody that reaches target, I think it's very, very dangerous. And it's also built on loose grounds that you should block GM-CSF. It's actually, there's one trial from China where they see in 3 out of 80 patients, they see a very, very minor GM-CSF increase. And we just got data from Singapore that the majority of patients have a reduction in GM-CSF. So if anything, they need excess GM-CSF rather than blocking it. So I'm actually in contact with a company who wants to launch the trial.
Okay, thank you, Bart. For the last questions, we'll we'll get to Stephen Collins. So the first question was from Lars Verreke, who asks about the immunosuppressed patients, whether those patients would benefit from early antiviral therapy. And then the second question is from Behruz Hassania, who asks not to lose the window of opportunity for treatment at the early phase. What do people have to do if they have mild symptoms but have not been tested for coronavirus? So I think the question would be, would there be any place for antiviral treatment strategies in patients with mild symptoms? That's the second question.
I would say definitely yes, but the problem is with detection of the virus, for which we are now using PCR, and so the turnaround time in our center is let's say about 8 hours, but it can take up to 24 hours. So what you do in the meantime, if you do give a drug in early on and you're not sure about the disease, you should have a safe drug. And there's some candidates like Camostat that could be used for that. It's a bit difficult in availability, but there's a trial ongoing in Denmark with that, and we're trying to start something here also. If you look at the other drugs that are available, like the chloroquine, you're not sure about the dosing that you have to give in the beginning, but you have the QT prolongation. So it's a weighing of both. With better diagnostics, if the antigen tests become more sensitive in future, so we have a sensitivity that increases from 60% where it is now, this might be far more easier to do. But yes, I'm a big fan of looking into PrEP or PEP for high-risk patients and putting them maybe on a longer prophylactic treatment than waiting for this infection to happen. Patients also present them quite late, and so we have an idea on how the virus, or at least how the RNA is disappearing. But looking at the nursing homes now, where a lot of the care workers are testing positive, being asymptomatic, there's another way of using the antivirals, and that might just be to stop the spreading of the disease also. But again, you could only do that with very safe and cheap, widely available drugs.
Okay, thank you, Stephen. I would like to conclude by thanking all our speakers and for today, and also I would like to thank our hospital pharmacy, our clinical trial center, HIRUS, our local clinical trial units, our collaborators, clinicians, and patients for making all this possible. We could not have done this without you. And also for this particular webinar, we would like to thank our ICT department and communication department for making this possible. Thank you very much. And thank you for the audience for listening and for your nice questions and interaction.
That's a wrap.